Good afternoon. We'll start now. Okay, it's already 2 o'clock, and this will be a long lecture this afternoon. Okay, so we will forego with the laughter exercise this afternoon because it's a long talk today. Okay, so I'd like to welcome everybody. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Include the names of companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk. As a reminder, please take the online learning cum evaluation test exercise for mastery of learning and have a perfect score to get the certificate. Abet has placed the link in the chat box already. So this is a sample of the certificate that you will be getting. Another reminder, 50 OLETE certificates will entitle one to a voucher of free ROJoson telemedical consultation. So let's now have a group picture taking before we start the lecture proper. Okay. One, two, three. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses that pep talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Low Value Medical Care, Unnecessary Diagnostic Test. This is part of the health issue course. The empowerment objective is for the lay people to have a better understanding of the importance of low-value medical care, specifically unnecessary diagnostic tests in the management of their health. Last week, we tackled the unnecessary prescription of medication. So this week, we will be tackling unnecessary diagnostic tests. The contents of the pep talk will be the following. For today, what is a low-value medical care? What different types, causes, how common, and then focusing on low-value diagnostic tests. What is it? Examples. What are the causes, types, and side effects of low-value or unnecessary diagnostic tests? And what are the tips in avoiding or reducing low-value or unnecessary diagnostic tests? As to the first topic, what is a low-value medical care? It's defined as a medical care or services that provide little or no benefits to the patients, have potential to cause harm, incur unnecessary costs to the patients, and waste limited healthcare resources. So when you say no or little benefit, this is in terms of effectiveness. So it is not effective. So it's low-value medical care. Potential to cause harm is in terms of risk for unwanted, unnecessary side effects or adverse effects and complications, and sometimes even death can occur with the medical services rendered. Unnecessary cost to the patients is in terms of money spent by the patients and families. Waste limited healthcare resources is in terms of unnecessary usage of government funding, which is finite, which has a limit, okay, or budget for the health of the citizens, like the PhilHealth, and unnecessary usage of finite number of services like diagnostic beds, tests, or procedures. Low-value medical care can also be equated to the so-called unnecessary or not needed medical care rendered to patients primarily because of no value or little value or benefit and with potential to cause harm, and secondarily because of unnecessary cost to the patients and waste of limited healthcare resources. It is also equated to unnecessary or not needed or not indicated or not in the patient's best interest when weighed against the other options, including watchful waiting and other more conservative measures. In contrast to low-value medical care, you have the high-value medical care, which is providing the best medical care possible, efficiently using resources and achieving optimal results for each patient. What are the different types of low-value medical care? So you have unnecessary medication. We tackled this already last week. Unnecessary diagnostic tests, which we will tackle today. Unnecessary operations or surgeries. So these are the three most common categories or types of low-value medical care happening in the world. So when you say unnecessary prescriptions of medications, so these are the prescriptions that has been done by the doctors that provide little or no benefit to the patients, harmful, incur unnecessary costs, and waste healthcare costs. And then examples of unnecessary medications, prescribing antibiotics for viral upper respiratory tract infection, which is not indicated, prescribing antibiotics for asymptomatic bacteriuria. Bacteriuria means you have bacteria in the urine based on the diagnostic test, and then prescribing medicines and supplements when they are not indicated. Low-value diagnostic tests is ordering of diagnostic tests that provide little or no benefit to the patients, may be harmful, may incur unnecessary costs, and waste healthcare resources. So examples are ordering pre-operative tests. When you say pre-operative before the operation, there are a lot of tests being done, supposedly for clearance. Okay, that's the habit, the practice of a lot of doctors in the Philippines as well as abroad, prior to low-risk surgery. Low-risk means that it's a surgery that will not carry a significant risk in terms of extent of the operation. Okay. Then another example is ordering MRI. Because of the advent of MRI, it's so popular. Even PET scan is also popular. Okay. It's being abused. Okay, so in this particular example, ordering MRI for non-specific low back pain. Okay. The other type of low-value medical care is unnecessary operations. This is performance of the operations which provide little or no benefit, harmful, incur unnecessary costs, and waste healthcare resources. We will tackle this next week. So examples of unnecessary operations or surgery: circumcision, cholecystectomy for asymptomatic gallbladder stones, cholecystectomy for gallbladder polyps. What are the causes of low-value medical care? So there are three factors. You have the physician-driven factors, patient consumer-driven factors, and the health system-driven factors. For the first factor, physician-driven factors, we know that physicians are the primary factor because of their greater influence in promoting, avoiding low-value unnecessary medical care, because they call the shots, they are the consultants. Usually, the patients just follow the advice of the physicians. That's why they're called the primary factor. Secondary factor are the patients or consumer. Okay, so these are because of their mindset, their desires, because of their biases, because of their practices. Okay, so which the physicians want to satisfy above anything else, and which usually lead to low-value medical care. So these are the physician-driven factors. Mindset of in the medical management of doctors. There are three types actually, but the two types that will lead to low value will be ritualistic and maximalist patients. Financial gain is another physician-driven factor, both incentivized or non-incentivized. When we say non-incentivized, they do things more on the business sense rather than a compassionate sense. Okay. Number three, physician-driven factor is wish to satisfy or please the patients. Okay. Then fear of malpractice suits. And then the last one is no clear explanation and presentation of options of management to advise the patient. There are three types of physicians based on their approach to medical problem solving, decision making, and recommendations. These are called the mindsets. Okay, there are three types: ritualist physicians, maximalist, and minimalist physicians. Ritualist physicians are those who make medical management decisions based on habits and not mainly on critical analysis. So this will lead to low-value medical care. Maximalist physicians are those who institute medical management that includes a lot of things nice to have, but that are not essential or needed in the patient management. So this again will lead to low-value medical care. Minimalist physicians are those who institute medical management that includes only which are essential, yung mga importante lang, kailangan lang by a patient in health restoration and maintenance. So this will lead to high-value medical care. The secondary physician-driven factor, as I said, is financial gain, which can be incentivized or non-incentivized. For the incentivized one, examples will be rewards given to doctors, to physicians, okay, who would do this, who would prescribe, who would operate on these patients, who would order diagnostic tests, and then in return, they get some stock dividends, perks, free trip abroad, etc., etc. Okay, so these are actually happening all over the world. Okay, for the non-incentivized kind of a financial gain, they do things to enrich themselves on a personal basis. Okay, so they have more business sense than compassionate sense. Okay, an example will be some physicians will own some pharmacy, and so they will prescribe drugs that will promote their pharmacy. Some would also own diagnostic tests, okay, services. Again, they might order diagnostic tests left and right. Okay. The other physician-driven factor is the wish for the patient to please the patients. Okay. So pleasing the patient on their mindsets and desires. Okay. Patients have their own biases, habits, and belief. Rather than explaining and educating and convincing the patients on what is the rationale for this particular care. And then fear of malpractice suit is also another physician-driven factor, because if something happens and then if the physician does not satisfy the patients, they might get sued also because of a misunderstanding or dissatisfaction. The last one is no clear presentation and discussion of the options of management, like the BRCA, benefit, risk, cost, availability of parameters. Okay, comparing these 4 parameters in terms of the options. Okay. So when you say high-value medical care, we usually look for the most cost-effective, not just the most effective one. So it might be the most effective, but it's very expensive, so it's not the cost-effective. Okay. So high-value medical care focused on cost-effectiveness rather than just effective options. So this is an example of BRCA table. Okay, on the first column are the options. On the second column, the benefit, the risk, then the cost availability option on the subsequent columns. The second factor is the patient-driven factor, which is usually the mindset and desires of the patients. Okay. Again, there are 3 types of patients. You have ritualist, maximalist, and minimalist. Okay. Just like the physicians, ritualist patients usually make decisions, okay, based on habits, fads, what are the trends, not mainly on critical analysis. So this will lead to low-value medical care. Maximalists, nice to have. They would like to have everything, okay, which may not be essential, okay, and then probably they're influenced also by their belief, by their mindset. This can also lead to low-value medical care. Minimalist patients are those who desire only the medical management that includes only the essential ones. So this will lead to high-value medical care. How common are the low-value medical care? Okay, very common abroad. Not only in the Philippines, but abroad, okay? So it has been there since time immemorial. So since 2012, there is a formal movement advocating high value and reducing low value medical care initiated. This was initiated when they start feeling the heat already because of a lot of government spending going on, so they cannot meet the financial requirements of the patients in terms of medical services. So this popular movement, which started in the US, which is very popular now, Choose Wisely, in 2012. So the mission is to promote conversations between clinicians and patients by helping them choose care that is supported by evidence, scientific evidence, okay, not duplicative of other tests or procedures already received. This is also commonly happening. Okay. Doctors are duplicating a lot of tests which are not really necessary, and it has been done. And then free from harm, and one care that is truly necessary. Okay. So this movement has been spreading globally across Europe and Asia to over 20 countries around the world. And there is now a formal tracking of low-value medical care. When I say now, up to this year, okay, 2022, there's a tracking of the hospitals who are doing a lot of low-value medical care. Okay, but in the Philippines, there's no such thing going on yet, except on some personal basis, like what I'm doing now. Okay. So again, it's also very common because in practically all prescription, all ordering of diagnostic tests and performance of operations, there's always a potential for risk for low-value medical care because of the three factors that I mentioned: physician, health systems, and patient factors. This is particularly when most of the physicians do not have that habit of presenting and discussing the data and processes with the patients in terms of benefit, risk, cost analysis, availability, okay, of the different options. So let's now focus on low-value diagnostic tests for today, okay? So as I said, I will discuss low-value or unnecessary surgery next session, okay? And I have discussed the unnecessary prescription last week. What is low-value and unnecessary diagnostic tests again? Okay. So it's the ordering of diagnostic tests that will provide little or no benefit to the patients, may be harmful, incur unnecessary costs, and waste healthcare resources. How common? Okay. Among the three types, low-value prescriptions probably is the number one. And then after that, the low value of diagnostic tests is the second most common. Operations, unnecessary operations, probably the third most frequent. What are the causes of the low-value diagnostic tests? Okay. Again, the three factors: physician-driven factors, patient or consumer-driven factor, and the health system factors. Okay. So you have, again, this general causes: mindsets of the patient, financial gain, wish to please the patient, fear of malpractice suit, no clear presentation, discussion of options of management. The other factor is mindset of the desires of the patient. Okay. The third factor is the health system factors, which include the following: facilitating, allowing, and no policing, no quality control of practices of physicians, inadequate public health education, patient-centered care management program, or patient empowerment program. And what are the types of the low-value diagnostic tests? Okay. Usually in terms of the possible causes. So ordering diagnostic tests that are not needed, in which just watchful waiting will do. This is an example. This is a type of diagnostic, low-value diagnostic test. Okay. Doing an inappropriate test, okay, which is not indicated. It's also a low-value diagnostic test. Not proven effective. Unsafe for all patients and to certain patients. Costlier than other equivalently effective tests. As we know, there are a lot of other options. Okay, so once a more costly test is prescribed, but which may carry the same effectiveness as another cheaper test, then it's a type of low-value diagnostic test. Again, too many non-essential diagnostic tests, too many which are not indicated, which is not inappropriate, which are inappropriate, etc., etc. What are the side effects of low-value diagnostic tests? So we have to have this baseline of information. All results and readings of diagnostic tests are not always 100% accurate. We have to admit that. Okay, this is a reality. There's no such thing as 100% accurate all the time, all the results and readings. Okay. So ideally, what are desirable are the so-called true negative, in talagang wala, or true positive, talagang meron. Okay. However, some may end up with false positive. Okay. False positive means meron pero hindi naman talagang meron. Okay. False negative, wala pero hindi naman talagang wala. Okay. Physicians must be able to distinguish between true and false results and readings or the interpretation. Potential side effects of false positive. Let's just focus on the false positive. Okay. Ito kasi yung pinaka more common problem with low value diagnostic test. Okay. So it produce unnecessary physical harm, psychological harm because you have anxiety over possible serious diagnosis. Yung pala mali. Okay, sinasabing meron pero wala. So initially you don't know kung talagang wala at talagang meron o wala. Okay. The cost, particularly on the test and treatment cascading. I'll discuss cascading, the concept of cascading later on, and then ways of limited healthcare resources. Example, false positive in routine testing for pre-surgical or pre-operative patients have delayed surgical procedures and lengthened hospital stays, both of which create health risk. A false positive test can impede a correct diagnosis, delaying or depriving a patient of appropriate treatment, and it can also lead to inappropriate treatment. Okay. So these are some of the side effects of false positive, okay, in various situations. Okay. The side effect of positive findings and diagnostic tests done for screening in asymptomatic patients which are ongoing, maraming nagpapa-executive check-up, walang nararamdaman, nagpapa-test, no? Okay. So a side effect kung may nakitang findings is the cascading of care. Okay. So which means cascading of care just means follow up after kung may findings, may marami pang gagawing test to follow through. Okay. So cascade of care just means follow-up tests, biopsies, invasive procedures to further determine whether the results of the incidental findings, okay, talagang tama o mali. Okay, but in the end, which might end up to be unneeded and or inappropriate treatment. Okay. Cascade of care is defined as a series of medical services often fueled or triggered by a clinician's desire to avoid even the smallest risk of missing a serious condition through diagnostic tests, yung mga maximalists, na? Okay, or sometimes ritualist physicians. They frequently begin with an unexpected result na hindi mo na akalain lalabas, may positive, okay, or unnecessary tests. Okay. This can lead then to cascade of other diagnostic tests. So in the US, okay, 99%, how prevalent is this cascading? 99% of doctors reported experiencing a cascade of care. Ang dami, no? Okay. 87% of doctors reported cascades that harm their patients. Okay, that harm the patients. And then 41% of doctors reported continuing the cascade even when they think it was not clinically necessary. Okay. So what are examples of low value or unnecessary diagnostic tests? I'll just give a few examples. As I said earlier, practically, it's very common. It's difficult to give all. So in the Choose Wisely website, you will see a lot of examples of low value diagnostic tests, okay, which they're trying to educate the physicians and the public to avoid. So examples will be ordering a pre-op test for clearance, as I mentioned earlier, ordering MRI for low or non-specific low back pain, ordering urine culture unless this is the advice of the Choose Wisely, do not order urine culture unless patients have symptoms consistent with urinary tract infection. So the reason for this recommendation is that a lot of physicians are ordering urine culture, okay, left and right. Okay. Avoid thyroid stimulating hormone screening in annual visits for asymptomatic adults regardless of age. Okay. So maraming error din sa thyroid stimulating hormones. So determinations. So if you use that frequently, you end up with false positive results and confusing results. Okay. Avoid routine prothrombin time. Ito yung mga test for the bleeding tendency. Okay. So a lot of surgeons are ordering this thing for the clearance. Okay. So the advice is to avoid this in a symptomatic patient. Use instead a history-based bleeding assessment test. Just ask the patient, meron ka bang history ng prolonged bleeding? Ayaw huminto, matagal huminto, kung nasugatan? Kung wala, then na-operahan ka na dati, nothing happens, so you don't need to order all these tests anymore. Okay. So don't perform PET scan, CT scan, bone scan in staging of early breast cancer at low risk for metastases. Okay. So at the moment, a lot of doctors, medical oncologists are ordering PET scan, CT scan for early breast cancer, part of the surveillance. Okay. Another advice is do not order all these tests in staging of early prostatic cancer at low risk of metastases. Kasi mga 1% lang magiging positive dyan. Sayang lang yung PET scan, CT scan, and bone scan. So I said, I just mentioned a few examples. There are a lot. Okay. So the last topic is what are the tips in avoiding and reducing low-value unnecessary diagnostic tests? There are 3 factors as mentioned. The question is, what can you do as a patient, as a layperson, to help in this one, to avoid the low-value unnecessary tests? So we cannot wait for the doctors to move, but they are trying to police themselves now, okay, because of the choose wisely movement. But how long it will take, how successful it will be, matagal pa yan. Na? Okay. So we have to do our part, your part as patient, okay, either for your own sake or for your relatives. Okay. You can empower them, you can teach them, you can advise them. So that's why we have this empowerment program, okay. So be always in touch with reliable medical information on the low value and high value medical care. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, kapangyarihan to gain greater control over decisions in the medical management of oneself in promoting high value medical care and avoiding low value medical care. Suggested strategies or recommended strategies by me will be, so be constantly aware of and vigilant against potential low-value ordering of diagnostic tests by physicians. Now that you have been presented this lecture, now you're now aware of such a term, low-value, okay, low-value medical care, low-value ordering of diagnostic tests. Okay, it's practically the same as unnecessary. Okay. Always aim and insist for a high value ordering from the physicians. Be proactive, unahan mo na sila. So in controlling and avoiding low value diagnostic tests. So make the physicians aware that you know the processes on how to reduce the low value and how to promote high value diagnostic tests. Then have a shared collaboration. Yung mga ibang doctor, pag alam nila, may alam ka, so they will collaborate. They will respect you. Okay. Before accepting a prescription for the diagnostic test, be sure to ask the doctors these things. What is your specific pre-treatment diagnosis with quantification of degree of certainty or probability? As I said, there's no such thing as 100% certainty. So you have to ask the doctor, what is your degree of certainty? Hindi pwedeng 50-50. It should be 60-40, 80-20, ganon, no? Okay. And then after that, what is the goal of the diagnostic test? Ano bang gustong nating i-achieve sa pag ginawa nating diagnostic test? Okay. And what are the options for further diagnostic, for the other diagnostic tests? The other diagnostic tests should include the watchful waiting. Watchful waiting is also part of diagnostic testing kasi ino-observe mo. Diba? So kung Kung may lumitaw, that's a diagnosis. Pag walang lumitaw, diagnosis pa rin yan. Okay? So is watchful waiting a good option for further diagnosis? Tatanong mo sa doktor. What are the chances that the medical condition will resolve spontaneously without diagnostic test? You have to ask them point blank, because most doctors just treat medical conditions as a disease that will not disappear. They will just treat them actively. So if the answer to this question is that more than 50% it will disappear, no, watchful waiting is a good option. What are the comparative data and information on various options in terms of benefit, risk, cost, and availability parameters? And then ask him, what is your recommendation on which one is the most cost-effective option? Always, if they cannot produce a table like this, always ask for the data on this: benefit, risk, cost, availability of the different options. 1, 2, 3. Okay, it can even be 4. Okay, hindi pwedeng isa lang one option. Okay, there are usually more than one option. And then in the diagnostic test, always include watchful waiting as a kind of diagnostic test. When the physician asks for your response to his recommendation, let's say I recommend this one, feel free to ask as many questions that you may have on the data and information presented, and ask him to control. And you volunteer, tell him to control. He says, Doc, tama ba yung sinasabi ko? Tama ba itong aking belief that this and that? Because you yourself have biases, you have mindsets, you have desires. Okay, so ask him to clarify whether it's correct or not. Okay, so you can come out with a very objective decision making. Then you are free and right to choose a second opinion if you want. However, when you do this, when you look for another doctor, make sure you follow the same processes, BRCA. Okay. So some more recommendations. We all know that in some cases, some doctors will have financial gains as one of the factors that will drive them to order this and that. Okay, so you usually don't know whether there are ulterior motives behind the physician's prescription of diagnostic tests. Okay, you don't know, and it's very impolite or baka masaktan sila to ask that. Okay, so the best diplomatic strategy is to prevent this ulterior motive is to ask the physician to just present and discuss the comparative data on the benefit, risk, cost, availability of the different options of diagnostic tests. Then analyze them based on the data that this was given to you. Okay? Make a judgment on the physician honesty, competency, and presence of ulterior motives. Okay. So in trying to please the patients, there are some doctors who have a good practice. Okay, so if you see a doctor who would say like this, I'm not going to prescribe a low-value diagnostic test just because my patient requested for it. Okay, I just think we need to talk. We have to discuss. Okay, so when I feel strongly that something has harms, mas hindi nakakabuti sa pasyente, then I guess I'm less likely to take that patient preference. The patient really should not force the doctors to write a prescription on what he thinks should not be given. Okay. So the other mga comments of mga doctors who are practicing high-value medical care, they will tell the patient, I'm sorry, your perception on diagnostic tests for these medical conditions are hindi totoo, myth, incorrect, unfounded. I have to correct you through these explanations. I'm sorry also that we have to decide on what type of diagnostic test to take based on hard scientific evidence and not based on fad, trends, popularity, and other practices. Okay, yung mga common practices in the community. My personal practice, I am a minimalist physician. Okay, this is my declaration. I order diagnostic tests only when indicated. I have a rational process in indication, selection, interpretation of diagnostic tests. To start with, for those who have been attending my pep talk since the start, I have this patient management process. Okay. And then I have this structured paraclinical diagnostic process. Okay. So the takeoff point for the paraclinical diagnostic process, which is the diagnostic test, okay, is the clinical diagnosis, which consists of the primary and secondary diagnosis. So after the clinical diagnosis, the next step to do is to determine whether a diagnostic test or paraclinical diagnostic procedure is needed or not. A paraclinical diagnostic procedure is a diagnostic procedure, it's the same as diagnostic test, that is done after the clinical diagnosis. That's why I said you have to ask the doctor first, what is your clinical diagnosis? Okay, so after the clinical diagnosis is arrived at, and its objective is to make the diagnosis more definite. Okay, the foremost indications for a diagnostic test can be stated in this way. If you are not certain on the primary clinical diagnosis and you need to be more certain before the treatment, then you have to go for a paraclinical diagnostic procedure. To decide on indications on the paraclinical diagnostic procedure, the physician used two processes: degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the primary and secondary clinical diagnosis. The physician should consider the following factor: how certain he is with the clinical diagnosis. If he's quite certain or very certain, in general, hindi na kailangan yung paraclinical diagnostic test. The quite certain clinical diagnosis becomes automatically the pre-treatment diagnosis. If he is not quite certain or uncertain, in general, a paraclinical diagnostic test is needed. Common sense lang, di ba? Okay. So whether a more definitive diagnosis is needed or not for some reason or another, example will be if the contemplated treatment procedure is very extensive, mutilating, risky, etc., then a more definitive diagnosis is needed. If the treatment for the secondary clinical diagnosis is the same as that of the primary clinical diagnosis, then a paraclinical diagnostic procedure may not be needed anymore. Okay? If it's different, then a more definitive diagnosis or diagnostic test is indicated. If there is a need for a paraclinical diagnostic procedure, then we use the BRCA. So the physician should list down the various options and then give the data on BRCA. And then after the doctor gives the data, the patient is asked what he prefers. Okay. It should not be the physician forcing his recommendation. So the physician tabulates as much as possible kung pwedeng maganda itong table. Kung hindi, at least when he explains, he has all these elements, okay? Benefit, okay, risk, cost, availability for the different options. So at this point, after explaining, okay, so he can only recommend, he waits and answers queries from the patients, and then allows the patient to decide and forges a shared agreement. Okay, so allows the patient to decide. This is reminiscent of what I told you. This is one way of avoiding yung mga financial, yung mga ulterior motives of the physicians. Okay. Once a shared agreement is arrived at, informed consent or informed refusal is formalized. If there's an informed refusal, the paraclinical diagnostic procedure is not executed. So you have the right to do that. If there is an informed consent, then the diagnostic procedure test is executed. But just before, during, and right after the diagnostic procedure, the physician advises the patients on the preparation, possible outcomes, and things to monitor. So assuming that a paraclinical diagnostic procedure is done, then the physician has to interpret the results. Okay? To do this, he uses two processes. He assesses the accuracy of the report and correlation with the clinical findings. So at this point, physician advises the patient on his interpretation and proceeds to the discussion of treatment. So with my structured paraclinical diagnostic procedure, I'm really aiming for a high-value diagnostic test and not a low-value one. Aside from using my structured paraclinical diagnostic process, here are some of my practices that run counter to the usual practice in the Philippines. Number one, I don't do routine preoperative testing for clearance prior to surgery. I do some tests only when indicated. Number two, I don't do routine CBC and urinalysis in patients with possible acute appendicitis. Yung mga pumapasok sa ER pag may masakit ng tiyan sa right lower quadrant, okay, CBC urinalysis kagad. Okay, so I only do them when indicated. For cancer surveillance monitoring, okay, I use symptom and sign-based approach and not routine diagnostic tests like bone scan, chest x-ray, tumor markers, okay? Because most of the time they are negative. Okay? I don't do routine thyroid function tests like FT4, TSH for patients with thyroid concerns. I only do them when indicated. So I think I'll stop at this point on the tips. There are a lot, okay? So summary and takeaway, I have presented and discussed all these various items, okay, as listed earlier. And then takeaway in relation to patient empowerment, be always in touch with reliable medical information on low value or unnecessary and high value, highly recommended medical care. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment, kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of oneself in promoting high-value medical care and avoiding low-value medical care. So I'd like to end this pep talk now, okay? On low-value medical care diagnostic tests, I hope I have empowered you to have a better understanding on the importance of low-value medical care, specifically for this topic today, unnecessary diagnostic tests in the management of your health. So let's now have, so before we go to the question and answer session, as a reminder, please take the online learning kung evaluation test exercise. Then 50 OLETE certificates entitled 1 to voucher for free ROJoson telemedical consultation. And then also a request is those who are not planning to take the OLETE, which I'm not forcing you, okay? So there I usually ask for a feedback in the OLETE, okay? Those who are not planning to take it, just type in your feedback in the chat box during the open forum and before we adjourn. Thank you. So let's now have a group picture taking before we start the QA. Okay. Okay, ready? All show your beautiful faces. 1, 2, 3. Okay. Okay. The floor is now open for questions, comments, recommendations, suggestions, disagreement with what I'm advocating. Okay. I suppose that all of us have experienced a lot of these things in our personal journey, in our personal encounter with the physicians that you have, okay? Even me, probably. Okay. Any questions? Any question on the chat box, Abet?
There is nothing at the chat box as of now.
Who would like to share their experiences? Those who are my cancer patients, I am sure you will agree with me that You're not doing yearly bone scan. You're not doing yearly CT scan, etc., etc. Okay. But you have heard of other patients who are doing that, right? Tama? Ellen, Delorio.
Tama, Doc. You never, in my case, ano, yung mammography, hindi nyo nga rin ako yan ano eh. At saka bone scan.
Bone scan. So,
And basta walang test.
yeah.
Walang unnecessary test.
Yeah. So, but there's a basis for that. We base it on your symptoms and signs. Okay. So if you have symptoms of cough, prolonged cough, then that's the time I do the test. No? Okay. So if you have symptoms of prolonged, when I say prolonged, yung persistent for 1 month, 2 months, the bone pain, then that's the time to do the bone test. No? Okay. Pero kung wala, you don't have to do all those tests because chances are they will be negative. Okay? Minsan pag pinatest mo, may findings, hindi sigurado kung positive or negative. So sabihin, let's say bone scan, sabihin may dark area, not sure whether, sabihin ng radiologist, yung reporter, not sure whether it's a metastasis or not. So papagawa ka na ng ibang PET scan na. Di ba? Okay, mga ganon. So, yan ang tinatawag na cascading. Cascading, no? So, once you see something, they will do a lot of other tests to follow. Okay? So, yung iba na operahan na di kailangan also because of that alarming finding. Okay. Okay. Any questions? Perla, anong tatanong mo, Perla?
Dok, may tatanong po ako.
Oo.
Kasi lately nagpa-CT scan ako, CT stonogram ba yun? Eh nung dinala ko sa doktor yung aking result, ang sabi dito is, there is a small faint density in the upper pole calyx. Meron daw maliit na bato sa aking right kidney, eh nirecommend na pupunta ako sa urologist. Tama po ba yun?
Meron kang nararamdaman?
Wala naman, doktor. Kasi sabi niya parang may maliit daw na bato, parang maliit naman daw, maliit daw, parang buhangin lang daw. Sabi niya, pupunta ako sa urologist.
Oh, kasi ang tumingin sa iyo, hindi siya urologist. Tama?
Hindi po doktor, gastroenterologist.
Okay. So, okay. Yan nga tinatawag cascading. No? Okay. So you did the test. Bakit ka nagpa-CT stonogram? So,
Kasi
may nararamdaman.
Matagal na ito last year pa, kaya lang hindi ko makapunta-punta kasi nga sa pandemic. Parang dito nga sa kidney, parang parenchymal, ano ba yun, yung meron nilang nakita noon sa sa ultrasound.
Okay.
And nirecommend ako ng, opo.
Okay, yan ang example of cascading. So wala kang nararamdaman noon, no, nagpa-ultrasound ka, may nakita parenchymal changes, di ba?
Opo, opo.
So yung parenchymal changes is not, when you say parenchymal changes, yung sa substance ng kidney lang yon, substance of the kidney. No? Okay. So hindi yung sa mga tubes, bato, ganon. No? Iba yun. No? So pinagawa ka ng CT stonogram. No?
Opo, opo.
So may nakitang bato ngayon. Di ba?
Opo, yung malit lang naman daw sa right kidney ko.
So yun ang sinasabi dito sa low value. Kung wala kang nararamdaman, you don't have to have test kasi mapapalaki na yung problema mo. No? Okay. So wala kang nararamdaman. Di ba? So anyway, andyan na. Siyempre yung gastro will always respect na yung other specialist. No? Sabi niya, urologist yun. Di ba? Ang titingin sa iyo. No?
Opo.
So yung urologist will tell you, most likely, if you ask my opinion, even though I'm not a urologist, if you have a very stone in the sa may calyces, di ba? Yung mga calyces yon nakalagay, calyces.
Opo, nakalagay.
Okay. nasa level ng kidney yun eh. No? So yung mga draining tubes, okay, hindi sa ureter. Pag nasa ureter, mas delikado yon, di ba? Okay. Ureter sa baba, no, magbabaka yon, no? Pero kung nasa itaas lang, naglulutang-lutang lang siya diyan, no? So hindi naman kailangan operahan. Baka the most that you will do will be kumisan, you just drink a lot of water, okay? O kumisan, you can give you some mga gamot na will parang alkalinize yung para ma-dissolve ng konti, na? Okay.
Oo nga po.
Sige. So, anong gagawin mo ngayon?
Iniisip ko nga po, doktor, kung pupunta ako sa urologist. Kasi last week lang ako nagpunta sa doktor so yung gastro, pinakita ko lang. Sabi niya, pupunta daw ako sa urologist. Nas ko bakit hindi sa nephrologist, urologist daw kasi doon daw sa mga bato.
Okay. So, pag bato, usually, how do you answer that? Kung sa nephrologist, pwede naman, nephrologist, urologist, no? Baka sabihin ng nephro, i-refer kita sa urologist. Di ba? So, kasi bato di ba? Kasi bato pwedeng operahan yan. Diba?
Opo.
Okay. So, kailangan operahan. So, kaya pwedeng diretso na sa urologist. Yung urologist, kung basta meron siyang magandang explanation sa mga options, wag lang opera ng opera. Kung meron siyang options na medical management, sasabihin naman niya sa iyo honestly, no? Na pwedeng hindi operahan, no? Okay. So i-weigh mo na lang kasi you see a nephrologist, sabihin ng nephrologist, ay wala akong alam diyan kasi stones yan sa Euro ka pupunta. Edi parang ping-pong ka na lang, pasahan ka. Okay. So sige, sa akin, you see a urologist na lang para diretso na.
Urologist.
Pero just ask him yung mga options for treatment. Ha? Wag lang operahan kagad. Ha?
Oo nga, ayaw ko naman doktor kasi malit lang naman daw ito, baka makuha pa sa gamot ba?
Tanong mo lang yung options.
Opo.
Okay.
May tatanong lang po ako isa pa. Ano ba yung unremarkable na result na nakalagay dito? Nakalagay kasi dito is the visualized portions of the liver are unremarkable. The gallbladder, pancreas, spleen, and both adrenal glands are unremarkable. Ano ibig sabihin po yun, unremarkable?
Nothing to remark on. Unremarkable is nothing to remark on in terms of findings. So walang findings. Okay? Walang findings. Walang abnormal findings. Unremarkable. So, anong suggestion mo? After my explanation, dapat ba anong phrase ang dapat gamitin ng doktor?
Wala naman siyang in-explain dito, doktor
Hindi nga. Kasi yung mga readings na yan, depende sa yung nagbabasa They can use any language that they want to use, di ba? So anong suggestion mo? Mas maganda kung lagay negative, walang findings, normal, di ba?
Yung parang mas gusto ko yung normal. Nakalagay normal sana kasi unremarkable parang meron siyang unremarkable. Sana nakalagay lang is normal, parang ganun.
Unremarkable. Okay, anyway, mahirap na i-control yan kasi depende sa nagbabasa yan Kanya-kanyang language yan no? Okay.
Opo.
So, pero ina-explain ko na sa iyo na when they say unremarkable, no? Walang findings. Okay. Okay. Walang findings.
So it's good as normal.
Yeah, it's as good as normal, no? Normal at the moment. Normal at the moment. Okay.
Thank you, doctor. Thank you.
You're welcome. Any more? We still have 5 minutes.
Doc, nabanggit nyo kanina yung urinalysis na you were mentioning na hindi naman kailangan. Opo. Sa experience ko, nare-recall ko, palaging may urinalysis. Hindi ko naman natanong kung bakit. Tapos ang mga result naman negative, negative. Now that I have yung ganito yung patient empowerment, siguro every time na, kasi check lang po ng check yung ano kung ano yung ipapa-diagnostic test. Hindi ko naman inaano kung tinatanong bakit kailangan ito, bakit kailangan ito. Now that I have attended this lecture, maybe kailangan kong magtanong talaga kung para saan ito, para saan ito.
You're talking about parang ano, we had a lecture on that in screening, di ba? Diagnostic, yung executive
Opo,
check.
opo.
So, depende sa iyo kung minimalist ka, maximalist, or ritualistic. Okay, kung minimalist ka, you don't have to go for those screening tests kung wala kang nararamdaman. No? Okay. Kung maximalist ka, syempre, even your doctors will try to please you. Gusto mo di sige, gawin natin. No, check natin yung urinalysis. As I said, pati CBC, ang dami, di ba? Every year, kung yan ang practice mo, meron kang mga test every year may CBC ka. May CBC urinalysis, no? But if you had one already, let's say this year, you don't have to have it repeated every year.
Opo.
Unless talagang meron kang napupuna, let's say maputla ka, no? Okay. Then you can have your test done, CBC, to see whether anemic ka or hindi. No? Okay. Kung wala kang nararamdaman, most likely normal pa rin yan. Then kuminsan, ang downside ng mga test niya, they will give you some readings which are not accurate also. Nagpa-fluctuate kasi yan So pag nakita mo may abnormality pero wala kang nararamdaman, anxious ka na. Ay, nako. Ay, nako. May sakit na ako. No? Okay.
Tama po.
Okay. How many have may questions before I give another comment? May questions? Wala. Okay. So I posted a week ago or this week yung TSH, yung thyroid function test. No? Okay. So may isang pasyente na abnormal yung thyroid function test niya, pinaulit ko. Okay? Then naging normal. Okay? Kasi kung based on the abnormal thyroid function test, iinom na siya ng gamot, di ba? Okay? Pero pinaulit ko, normal. No? Another patient, two in a row yan Another patient, babae naman, nagpa-thyroid function test siya, mataas yung TSH niya, mababa yung T3, no? So ganon. So if you see such a result, hypothyroid siya, bibigyan po ng gamot, di ba? So ang ginawa ko, wala naman siyang symptoms of hypothyroid, wala siyang nararamdaman. So pinaulit ko yung test, normal, no? Okay. So yung sa akin din, personal experience, 2017, nagpa-test lang ako because sabi ng asawa ko, magpa-test ako kasi medyo nalalanta ko, gano'n. Okay, so I went for a test, ganun din, TSH mataas. No, so I don't believe it. No? So I have it test after 1 week, normal. So if I believe on the test, iinom ako ng gamot, di ba? Matagalan na yun. No? So that's those are just anecdotes that you have to be careful with all those tests. No? So kung di mo maiwasan to go for the test, no, make sure that somebody will know how to interpret it. No? Yung doctor must know how to interpret. Huwag lang sasabihin na abnormal ito, no? So gamutin na kita. Okay. You have to check kung anong nararamdaman ng pasyente. Kung siya nagtutugma sa nararamdaman ng pasyente, pwede mong paulitin kasi yung diagnostic test pwedeng mali rin. Okay? So, any more questions? Any questions, comments? Wala na?
Wala na po.
3:01 pa lang. So, we call it a day. 3 o'clock na. Wala nang tanong? May pahabol?
Wala naman sa chat box.
Okay. So next week, we will have operations naman, unnecessary operations. Na? Okay. So basta tandaan lang yung proper, the three most common types of unnecessary yung low value medical care, prescription, diagnostic test, and then yung surgery operations. No? Okay. Okay, if there are no other questions, let's call it a day. We'll see
Thank you,
each other
Doc.
next week. Okay.
Okay, Doctor.
Thank you again, Doc.
Bye.
Thank you so much.
Ano to mag-leave? Leave. Ano mo nung leave? Yan. Leave meeting. Pindutin ko pa to.